Thank you all for your attention. We're going to move on to the third section entitled Postoperative Considerations. And our first talk is by Dr. Sarah Teele. Dr. Teele is the medical director of our cardiac ICU at Boston Children's Hospital. She's also the director of the Senior Fellowship in ICU. And her talk tonight is entitled Simplifying Complexity, Managing the CICU Patient with Heterotaxy.
Good evening, everyone. Thank you very much to the organizers, and thank you to all of you for your time and interest tonight. Talking about the CICU management of heterotaxy patients in 10 minutes or fewer is an incredibly daunting task. Having said that, I love taking care of this group of patients, and I find their challenges and complexities to be opportunities for improvement in how we care for our patients and for their ultimate long-term outcomes. And so my goal tonight is to empower and inspire all of you. But my first thing I want to say is that heterotaxy syndrome, like many things in Mother Nature, has predictive patterns. And we're going to go through some of those and reinforce some of the things that Dr. Shidlow mentioned early on, really to help out your ICU teams. The second is that this is a disease that requires a diverse team. And I don't just mean your subspecialist across your hospital, across your program. I mean diversity in terms of the professional clinicians taking care of your patients. So your nursing staff, your NPs, your respiratory therapists, pharmacists, nutritionists, et cetera. So with those two things in mind, both the predictability of some of the patterns, as well as the idea that you need a diverse team, we're going to move forward. Cardiology, we've talked a lot about that tonight, so I don't want to dwell here. However, I do want to recognize that we are lucky we have a designated cardiac ICU at our hospital. I appreciate that that's not true in every institution, and I would ask that if you've got a PICU that takes care of mixed groups of patients, that you think about champions within that PICU that you can kind of bring into the fold of cardiology. We're going to talk a little bit about airway and pulmonary function in these high acuity patients, and again, emphasizing the importance of respiratory therapists, immunology, and GI. So we'll touch on each of these. In the background, of course, are other specialists across your institution. Your radiologists are critical. They're going to be the ones that help you take a look at those plain films, so CT, MRI, and ultrasounds, and say, did you happen to notice this? But you want a group of people who's really invested in this patient and knows what they're looking for or could be looking for. Your anesthesiology team, and it's not just because I'm a ginormous fan of Dr. Nasser, but also because we ask them to do incredible things. Please take my hemodynamically vulnerable patient to the main OR or to interventional radiology because they need this procedure. So you need anesthesiologists who are excited to be part of this with you. Our geneticists, we touched on that earlier on, and we're really hoping the future is there. And then the family. This has been talked about at this meeting already by folks like Dave Wessel, but involving parents early on in that fetal testing, getting buy-in, recognizing the expectations around the complexity of this disease. And we've talked a little bit about the outcomes. We know these patients are higher risk for needing tracheostomy as well as ultimate mortality. And so having a family that understands some of those up front and gets the support of your social workers, your child life, et cetera. Quickly going through the cardiac pieces for our ICU folks. Again, if you don't have a dedicated CICU group of intensivists, I would ask that you find some PICU folks who geek out like we do. There are some familiar expected patterns. So for example, if I hear that we're about to admit a neonate who had a fetal imaging consistent with an unbalanced canal, double right ventricle, pulmonary atresia, a right-sided stomach, I want to know did they see the pulmonary venous return, because I know that in asplenia heterotaxy, which that child sounds a little bit like they might have, that there's a higher incidence of total veins. In addition to that, you want your intensivist to understand and ideally participate in those pre-op considerations. We have a department-wide med-surg conference where that's an opportunity, but there's some really meaty discussions that came across, and we talked about those BIV discussions that are going to help your intensivist understand why we did the surgery we did, the timing of the intervention, and what kinds of technical challenges may have existed, whether that's in the anatomy up front and potentially the LV to AO pathway, or whether that's the cannulation strategy in the operating room. And that helps guide some of our anticipated postoperative course and future goals. Is this someone that we expect to get through relatively efficiently, or is this someone that we think may struggle, and if so, why? And how can we mitigate that on the front line? And ultimately, where are we trying to get this patient? It's not just to the outpatient setting or a step-down unit. We're thinking about the long term. What are they going to be like when they're a teenager and an adult? And are they somebody that we're going to eventually think about needing our heart transplant folks to be involved in? And if so, how does that inform our care now? The pulmonary stuff is fantastically interesting and fun, and we could talk about for this entire session tonight. But one of the things I have noticed that is it's incredibly important that your team is all on the same page when it comes to the anatomy. If you have bilateral left lung morphology, then asking your pulmonologist to do a bronch without informing them of that is kind of mean. We've actually had people looking for right upper lobe takeoffs in patients who don't have a right upper lobe because they don't have a phenotypically right lung. And so that's increased sedation time for the patient, it's increased frustration for the team, and it's unnecessary. So making sure you have a group that's all on the same page. The ciliary stuff is fascinating, and I hope we learn a lot more about this very quickly. It's not just about density, but it's about function. And how does that inform our thoughts around muscle relaxation, our use of beta agonists early on, our looking at whether or not patients come in with infectious organisms because they have long-term bronchiectasis and may not have normal flora, and should we be adjusting our postoperative infectious therapy for that reason? We are working on the airway clearance thing, and Dr. Shidlow mentioned this earlier on. This is a multidisciplinary group that includes respiratory therapy, nurse practitioners, as well as pulmonology and pulmonary, and the folks in the CICU. We're really trying to come up with something that's practical, not just something that we can say we do this, but because we want to improve length of time on ventilator. And we want it to start ideally preoperatively and get all the way through to discharge to the step-down unit and then even potentially discharge home. Patients often have subtle findings. You can see this child has left upper lobe hyperinflation. That's not uncommon, and that may be due to intrinsic airway issues, it may be due to the cardiac complications, or it may be due to ciliary dysfunction. A better understanding of this is really necessary. Dr. Chidlow touched on the immune function, and I would say it's interesting. The data suggests that there's no increased risk of nosocomial infections in our heterotaxy population, which I find surprising, but it's out there. What is perhaps more important for the intensivist is the patient who comes in from the outside. So this is a kid presenting to their primary care pediatrician, to cardiology clinic, to the ER. If they are functionally asplenic, we know that they're a higher risk of sepsis and meningitis. So that child who comes in with subtle findings of neurologic changes, that's an important kid to jump on right away. And so knowing some consistent measure of their splenic function up front, if they come in on antibiotic prophylaxis, that may not protect them from the meningitis, but it's a giant red flag to those frontline providers. Maybe I need to think about this a little bit differently. The other piece, and I put this up just as a reminder, you can see in the bottom left of these lovely splenules that they saw in CT, that the number of spleens, so single or multiple in heterotaxy patients, is not a reflection of the actual immune function. So in other words, you can have polysplenia and not have normal splenic function. And I think many people don't understand that, especially out in the community, and it's important that we communicate that piece. The GI stuff is so fascinating and so much fun to take care of, but also incredibly challenging because oftentimes it's quite subtle. We know these kids are set up for malrotation or non-rotation, depending on your semantics, and upwards to 30 to even 90%, depending on which papers you read out there. This patient on this image has malrotation with midgut volvulus. That's a pretty obvious one, but we've had trouble with some of the more subtle things. The LADS bands and a distal obstruction, for example, has left us scratching our heads until we finally begged our general surgery colleagues to please just go in and do an XLAP in this patient, recognizing that was incredibly high risk and we were not clear on the yield, but that's actually what ended up happening. But that kind of shared historical knowledge is so critically important, and it helps get buy-in on some of those really difficult cases. Across the board, there's an incidence of microgastria, which is important to know because those kids have feeding intolerance. And so your nutritionist needs to know that kind of information when we're talking about increasing volume of feeds and a child's not tolerating that. Is that because their underlying hemodynamics are suboptimal? Is that because they have microgastria? Is there something else going on there? The GI stuff does have some nice asplenia versus polysplenia separation. You're going to see hiatal hernias more often in the asplenic types. Those can be super subtle. This is not subtle, but some of the ones can be a little bit less obvious, and that can be hard to see on a plain film unless you got a belly full of barium. So things that you want to look for, things your radiologists want to look for. So having somebody in your radiology group who's really switched on to this is remarkably helpful. The polysplenics have all the cool GI stuff. We see biliary atresia with that group, which of course is a very unfortunate diagnosis because those are often not great candidates for the Kasai procedure. Pre-duodenal portal veins and annular pancreas can both lead to obstruction of the small bowel and are worth thinking about, but unusual and not necessarily on the forefront of everyone's mind. And Abernathy syndrome, which is hypoplasia or absence of the portal vein, is associated with pulmonary hypertension, which you can imagine is particularly tricky in some of our single ventricle heterotaxy patients. So, in summary, please feel empowered to take care of these awesome group of people. There's so many opportunities here for research and quality improvement. As Dr. Chowdhury mentioned early on, the idea of genetics guiding the phenotype, or a better understanding of the genetics and its association with phenotype and how that can empower our bedside providers is a really incredible thing to think about and something we're super excited about. Collaborative efforts across your institution, across the country, around the world are going to be necessary if we're going to get better at taking care of this rare disease. And all of that's going to inform our teams and really strengthen the team expertise. Thank you.
Thank you, Sarah. And our last talk for this section by Dr. Christina VanderPluym. Dr. VanderPluym is an advanced cardiac therapies cardiologist and is the director of our VAD program and our cardiac antithrombosis management program. She also co-directs the stroke and cerebral vascular program at Boston Children's. And her talk is entitled "The Clot Thickens: Cardiac Medical Management in Heterotaxy."
All right, thank you very much. And I greatly appreciate the opportunity to be here today and greatly appreciate your attention, as I realize after a long meal and desserts, everyone's probably getting a little bit fatigued about hearing us talk about heterotaxy. But I think in listening to all of the innovations that have occurred and the medical feats that have really been accomplished over these last few decades in understanding the population, you have to take a step back and ask ourselves, why are we doing this? What is the goal? What is the goal of putting our patients through the echoes, the labs, the caths, the appointments, the surgeries, the hope, and sometimes, unfortunately, the grief that we have to share with them? And the reason that we're doing all this is because we don't want our patients just to survive. We want them to thrive. And we've been able to accomplish this because of the collective wisdom and experience that's been gained through unfortunate experiences as well as many successes. And so beyond the ICU, beyond the surgeries, these patients go out into the world and live their lives. And we want to prevent as many bad things from happening to them. And we do that through anticipation, prevention, and treatment. And we realize that these remarkable reconstructions require maintenance of the vulnerable myocardium and the endovascular system. The reality is that these surgical and transcatheter interventions do increase the risk for thrombosis, be it either venous, arterial, or intracardiac, as well as myocardial dysfunction. And this can present as very subtle systolic dysfunction, which is just transient post-cardiotomy or post-procedure, to progressive diastolic dysfunction due to increased wall stress, subendocardial ischemia resulting in fibrosis, and progressive restrictive physiology. So beginning with thrombosis, when you look at the hematological considerations for heterotaxy, what's actually surprising is despite their multifaceted, multi-organ involvement, there's actually little hematological involvement associated with heterotaxy. And there's quite frankly no associated inherited thrombophilic conditions specifically related to the heterotaxy syndrome. That said, they are at increased risk for thrombosis due to the coexistence of things such as like LV non-compaction cardiomyopathy, resulting in areas of hypertrabeculation and stasis that could predispose to intracardiac clot formation. They also have a high burden of bioprosthetic materials in the form of grafts, shunts, and valves, and the body's natural response to endothelialization can sometimes result in pathological thrombosis. These patients do have a requirement for instrumentation of vessels, be it either in the form of cardiac caths, arterial lines, or PICCs. And as Dr. Hoganson referred to, we are evaluating their flow dynamics, and we know that this patient population has altered rheology, leading to increased shear stress on cells. And in terms of its manifestation clinically is that increased shear stress on red blood cells results in hemolysis. And the long-term sequelae of hemolysis can have a myriad of deleterious effects on a variety of end organs, as well as impact your endothelial system, resulting in increases in systemic and pulmonary vascular resistance. Its impact on platelets is increased platelet activation that ultimately leads to a prothrombotic state. So how do we address these considerations in this population? Well, I think as you guys have heard, this population is unique, and ultimately you can't take a one-size-fits-all approach given the heterogeneity of the anatomy and the ages, as well as the anatomical palliations that these patients go through. So our thromboprophylaxis plan is tailored to the patient based on patient-specific risk factors, such as known thrombophilic conditions, past history of thromboembolism or inflammation or other intercurrent illnesses, anatomical risk factors such as shunts, valves, or areas of stasis, and then procedural specific risk factors, be it instrumentation of vessels with cath or other non-cardiac procedures that may place the patient at increased risk of bleeding and ultimately thrombosis. Now, if a patient is to develop a clot, or if we're trying to prevent a clot, we are fortunate now that our armamentarium of antithrombosis agents has dramatically expanded, and we have many new options for this very old problem that is clotting. We at Boston Children's are high users of an agent called direct thrombin inhibitors, or bivalirudin, and this is an intravenous medication that directly inhibits thrombin. It's been about now 7 to 8 years that we've been using bivalirudin, and our experience really grew out of our parallel experience with trying to prevent strokes and other major thrombotic events in patients on ventricular assist devices. And for those of you familiar, the Berlin heart is one of our primary ventricular assist devices used in children with advanced heart failure. But unfortunately, historically, these patients came with a 30 to 50% risk of stroke. And with the adoption of bivalirudin, we've been able to reduce that risk of stroke down to less than 10%. And some of the features of DTIs make it specifically unique and well-tailored for pediatrics, specifically the fact that it binds both clot-bound and circulating thrombin, which allows for increased natural fibrinolysis, allowing for increased resolution of clot. It also has much more predictive dosing in pediatrics, which is obviously advantageous for a high-risk population. Moving beyond intravenous medications, we also look to the world of DOACs, or direct oral anticoagulants. And specifically, we use apixaban for the prevention and treatment of thrombosis as an alternative in many circumstances to warfarin and Lovenox. We are likely one of the largest users of apixaban globally, and participating in the Saxophone trial, which was a pediatric heart network trial specifically designed to evaluate the safety and efficacy of apixaban for children with acquired and congenital heart disease. We found that we established a dosing regime that was safe using commercially available tablets of apixaban. And so we have published our most recent experience, or early experience, of 219 patients aged as young as 2 months upwards to adulthood, of which close to 80% were treated for prevention of thrombosis and 21% for intracardiac, venous, and arterial thrombosis. And with this dosing regime, using levels, we were able to, as I said, use commercially available tablets and demonstrate 95% resolution of thrombosis and a very low adverse event rate of major and clinically relevant non-major bleeding events. Moving beyond thrombosis and the endovascular system, we have to support the myocardium. And we do that by enlisting our partners in the heart failure or heart transplant group. And I know when people think of enlisting that group, otherwise named as advanced cardiac therapies, they immediately think that these patients need a heart transplant. And what I want to implore to you all is that there's so many more options available to this patient cohort, given the fact that we have an expanding array of pharmacological agents that are now being evaluated for heart failure in our pediatric population. These agents include varogustat, or Vucova, which is an oral soluble guanylate cyclase stimulator that's currently being evaluated for patients with dilated cardiomyopathy and a reduced ejection fraction. There's an ongoing trial right now, but I think that their applicability to the congenital population and those with heterotaxy is on the next. SGL2 inhibitors, or dapagliflozin, has generated a lot of attention in adult heart failure management. It's been shown to reduce the risk of hospitalizations in heart failure, as well as reduce the rate of decline in kidney function. Now, while its mode of action in heart failure is not clearly understood, we do use it in our pediatric population as a weak diuretic, and we've now been using it in children greater than 6 months of age and up with no adverse events. Salcubitril or valsartan, otherwise known as Entresto, has completed its clinical trial in pediatrics, the Panorama Heart Failure Trial, with an improvement in biomarkers for heart failure in this group as compared to those with enalapril. In addition to pharmacological therapies, there is a large array of mechanical circulatory support options for the heterotaxy complex congenital heart population. In short term, we use ECMO as a fast and effective way to provide support for the both pulmonary and cardiac systems. And we can do this through either peripheral or central cannulation for direct unloading of the LV. In addition, to augment LV decompression, we use Abiomed Impella 5.5 or CP, which is a percutaneous FAD that's placed in combination with our interventional cardiologist for acute LV support in conjunction with or in isolation of ECMO. We use all types of durable mechanical circulatory support, namely the Berlin Heart X-score, the HeartMate 3, and PediMeg and CentraMeg, to support children with complex congenital heart disease and heterotaxy, not just for weeks, but months and years. Heart transplantation is a viable option for patients with heterotaxy, and I appreciate that for decades we've considered the heterotaxy population to be particularly daunting when it comes to transplantation considerations, that being a population who is immunocompromised and who will be already additionally immunocompromised with the agents that they receive. And as such, for many years, this has been considered a population that may be a contraindication, but ultimately, with expanding data, we are demonstrating that the contemporary outcomes for heart transplantation in heterotaxy is encouraging and continues to improve. There's a multitude of publications, be it through either UNOS and FIS data, as well as through PHTS, that demonstrates that while early mortality for heart transplant recipients with heterotaxy is lower than those with other forms of congenital heart disease and cardiomyopathy, that conditional 1-year survival is equivalent, and that acute rejection between these groups is generally equivalent as well. What's interesting to see is that VAD use was notable in 10% of heterotaxies as well as 11% of other forms of congenital heart disease. So that, at least for mechanical circulatory support, we're not considering heterotaxy itself to be a limitation in providing that support. So with all of that said, we are improving the outcomes for these very complex patients, and we're doing this through surgical innovation. We're doing this through the collective expertise of a multitude of different physicians, allied health groups, nursing, and parents. And it's really the unwavering compassion and commitment to share in this uncertainty, the fear, the anxiety, the grief, as well as the relief. And that's ultimately why we're doing this all. So thank you very much.